great. I guess I can go ahead at least start and do an introduction. Again, thanks so much everyone for being here, especially Dr. LaCroix. Just a brief introduction about her. I'm sure you all know her, but she's a board certified forensic psychiatrist. She attended the University of Washington for medical school and psychiatry residency, and then completed her forensics fellowship at UC Davis. She's been with the program here, the psychiatry residency track, since its birth, basically, and has served as the assistant director from 2009 to 2011. She also currently works for Saint Al's as a CMO of BPA Health and works as a clinical associate professor through the University of Washington. And she works integrally with our residents here in regards to teaching telepsychiatry and forensics. She also helps with resident supervision, didactics, and mentorship. And she has been a really busy lady. She has previously served as the president of the Idaho Psychiatric Association, the assistant training director for the Naval Medical Center Psychiatry Residency Training Program, assistant professor for USIS Medical School, and psychiatry clerkship coordinator for the WAMI Idaho track in the past. So thank you so much, Dr. LaCroix, for taking time out of your busy schedule to be with us today and presenting this very juicy topic to us. It sounds super interesting.
Yes, thanks. Welcome. A bummer to be in 2D, so I can only see a couple of you at a time. If I'm going to try to plow through, there's a lot of questions. It's a sad but also titillating topic. So I'm sure will be some things you might want to discuss. I'm going to try to burn through things and have some time at the end. I will let maybe Kelsey, if you could help me out if there's a chat element to that, and we'll just get going.
Yeah, of course.
So kind of, and in fact, I might have to hide us so I can actually see my own. All right, now you're all hidden. I'm just talking to myself. So kind of what we're gonna do here is go over the scope of the problem. And actually, before I hide you, I'm gonna see if I can see if anyone knows how to do their raise their hand function. But how many of you have heard of this as an issue or knew of this as an issue within healthcare? I see Larry, I see a couple people maybe. So not all, some, unfortunately is more prevalent than we probably think about on a regular basis. There are tons of cases, sadly, but through a few kind of more recent and more infamous cases, we'll talk about the scope of the problem, talk about kind of motivations of perpetrators. They're, obviously healthcare providers, so why would they kill their own patients? There's some different theories. They're trying to become a hero or an angel of mercy, and then get an idea of some of the demographics of perpetrators through some of the research that's been done, and be aware of some red flags, because at a minimum, I'd like you to leave thinking about it. And we're often the first folks who identify weird and suspicious circumstances, either via the coworker themselves or through the acts. And so it's our duty to be aware. Why this topic? Well, I became aware of a case that just, that was at the VA. I was also a staff physician, as many of you know, at the VA for 6 years, and I was a naval psychiatrist for 4 years. So I have worked a lot with veterans, and so there's been multiple cases that have occurred in VA hospitals, but this one is the most recent. She was just sentenced last week. Her name is Reta Mays. So the big tagline, and you can Google search her, she's all over the place, a veteran who killed 7 other veterans at a West Virginia hospital. Obviously their families want to know why, but so do we, right? So what we do know, she was 46 years of age when she was arrested. She was a nurse's aide in the Lewis A. Johnson VA in Clarksburg, West Virginia. She ended up being caught, investigated, and pled guilty, in part because the death penalty was on the table, to 7 counts of murdering patients with insulin and 1 count of assault with intent to kill, also related to insulin. She was sentenced, like I said, recently, May 11, and she received 7 life sentences plus 20 years. Because this took place at a veterans hospital, this was a federal case, and so it was the United States versus Reta Mays. And in federal sentencing, I don't know how many of you, I know there's a few of you from corrections here locally on the call, but a federal sentencing has very different algorithms, and so it's not a loose kind of sentence from the judge. There's certain algorithms. It's all very mathematical. So in terms of how many victims and all sorts of things, there's a metric that goes through to determine what potential sentences there are. But there was a range possible, and she ended up getting 7 life sentences plus 20 years, 1 for each victim and the attempted victim. The victims ranged in age from 81 to 96. So it gives you kind of the first clue of the most vulnerable populations to this type of act. And they took place between July 2017 and 2018, the last 7 very closely together within a few months. One of the quotes that people talk a lot about with her is that when she was interrogated, she said, you know, something always happens when I'm in the room. I don't know why. I'm so unlucky. And you can see that in a healthcare setting where we're all trained to help each other and support each other, where, you know, someone might interpret that who's working with her as, oh, don't be so hard on yourself, you know, the first or second time that she's on shift and this occurs. She in particular was a nurse's aide who worked a night shift with folks on a kind of a critical care unit. So she was there at night. There were other staff members present, but on her shift, what became apparent after several times was a suspicious death of an individual by hypoglycemia, but they were not diabetic. Autopsies, once the investigation determined that this was the case, were able to be done on a few victims, and they exhumed bodies to try to do chemical analyses to see what happened. And I'll talk about that at the end. But they, in some cases, also were able to find the needle marks and tissue evidence of insulin. So they also found in the course of the investigation that you know, Big Brother is always watching. Those of you who use government computers, that her Google searches included famous female serial killer, insulin, and a Netflix movie viewing of Nurses Who Kill. They're not all that easy as far as collecting evidence, but this is a few photos of the men who passed away. What's interesting about these cases, because your first thought might be, what type of killings would these be based on the age? And I'm going to let people unmute and just sort of shout out their thoughts. What would your first thought be?
What do you mean by what kind of killings? Like what method, or what would they be legally categorized as?
Like eugenics or?
Right, like it's a euthanasia or mercy killing, right? You might think, oh, poor people were suffering, they were older. Well, it turns out,
potassium.
Yeah, so good pre-guesses on everything. So it turns out that in particular, what was not good in these circumstances is that each of these gentlemen, although they were octogenarians, were not on hospice, they were not on death's doorstep, and they were all projected to have been discharged, you know, or there for a temporary reason. It wasn't a long-term care unit, it wasn't a hospice floor. So that made this a bit more of a disturbing case in that regard. So other disturbing things, and, you know, I mean, this is just arrested, these happened just a few years ago. There's some concerning things. She had no formal education as a CNA, but she was hired as a nurse's aide. She had been fired, from a corrections job as a correctional officer due to harsh treatment of inmates. They never checked that. And if you think about that, right, when you hire someone in healthcare, you don't necessarily look at other types of jobs and why they were terminated closely. And in this day and age, it's very difficult to really get the background on why somebody might have been terminated. She had a spouse who was in prison for child pornography, a federal case as well. In fact, same judge as her judge. The VA had itself had a number of failings in this regard, and there's a huge civil lawsuit in process where folks are being, victim families are being paid, a lot of money. But some of the big failings included they didn't have a Pyxis or an automated dispenser. There was access to medications and other things, and unsupervised time with folks alone at night. So what is a serial killer? And you might think, well, it's pretty obvious, but actually there's been, a consensus. So typically, historically, it's been thought of as the number of killings, right? You're a serial killer, it's math. You have to have more than one, right? But there's also, it's not just more than one, because that could be a mass killing, right? So it has to have a temporal space in between or a cooling off period to make it serial. Versus, like I said, a mass killing, which is defined as 4 or more in one incident. And the obvious version of that we unfortunately see more recently is mass school shootings or shootings in general. So it was one definition that was put in place in 1998 in the Protection of Children from Sexual Predators Act. Is that the term serial killings means a series of 3 or more killings, not less than one of which was committed within the United States, because this is a United States code, having common characteristics such as to suggest the reasonable possibility that the crimes were committed by the same actor or actors. So it doesn't preclude there being more than one person. There's actually an FBI murder symposium, which sounds very exciting. And they defined it, so these are experts in serial killing and murder. They defined it more simply as the unlawful killing of 2 or more victims by the same offender or offenders in separate events. Assuming some of you have heard of the FBI's Behavioral Health Unit, or BOW, it's been made famous by a Netflix show called Mindhunter, for those of you who've spent a lot of time on Netflix in the last 18 months. And that showed the inception of the program in the 70s. But it has 3 departments: crimes against children, crimes against adults, and a counterterrorism and threat assessment unit. And they are often called in with serial killers to help in the investigation. So they kind of analyze the cases, gain consensus on some of the factors. When you look, one of the things with serial killers is they don't often freely admit what their motivations are or what happened. They have different backgrounds. And so to take these cases and look at things that might be similar, what risk factors there are is obviously of great interest to prevent this from happening. And to detect it. And of course, there's no harder place to detect than within healthcare and in places where folks are acutely or severely ill and there is already a risk of death that makes it even more challenging. A key concept by the FBI is that in serial killers, the offender selects a victim regardless of the category based on availability, vulnerability, and desirability, right? So keep that in mind. Not to become a serial killer, but as we talk about the topic. So what is serial killing in healthcare, right? Some of you may not, it's not something we think of. We think of helping people in healthcare, but it's cases that link clusters of suspicious deaths, typically cardiopulmonary arrests, in a patient population to the presence of a specific care provider, okay? And in the presence of, because as you also are aware, multiple people are actively treating someone. So it's not obvious initially that it's one person in particular. So it takes a while and you narrow down. But if one particular staff member seems to be on duty each time, that is a flag, and we'll talk about those later. One of the most preeminent researchers in this area is Beatrice Crofts Yorker. She's a nurse at the College of Health and Human Services at California State University, not on LA, but in LA. One of her seminal studies was a 2006 paper on serial murder by healthcare professionals. She and her team did a very extensive search of cases of healthcare serial killers worldwide. And they spanned, time frame 1970 to 2006, and they looked at not only legal records, depositions, so they pulled as much information as they could. I think they found about 147 cases, and these would have been prosecuted cases, and weeding out certain factors, like if there were some other issues that made it not as clear that it was a serial killer case, they got weeded down to 90 cases total. What did they find? All right, here we're gonna have some more guessing games. So unmute yourself. And what country do you think has the most prosecutions for serial murder of patients?
US.
Ding, ding, ding. You are the winner. 40%, okay? And across 22 states of ours, they have had convictions. There are 21 other countries, though, where Germany is #1 and Wales is #2. All right. How about which profession is most commonly found to have committed serial healthcare murders?
Nurses?
Nurses?
Doctors, crazy doctors.
You would think. Nurses, including licensed practical nurses, vocational nurses, 60% of the serial killers were nurses. Aides came in a close second, and MDs, 12%, although the MDs have been more prolific. There's, better access, better means as far as success. And then there's another category where it's kind of split up and too hard to quantify. Respiratory therapy, physical therapy, etc. All right, how about gender and race?
White males.
Interesting. Anyone else?
White
You think
female?
male serial killers? You think serial killers will be males, right? It's kind of a bias we have against that population. White is correct. The white race is overwhelmingly committing these serial killings in healthcare, but the gender thing is interesting. Women were by far, over half. There's some other math science behind this, but women were 49%, male 44%, but it's disproportionate for males because they are a smaller proportion of nurses, right? So there you have that. And then we'll stop the quiz part because it was too hard to keep doing these flying in things. But most common settings, hospital units, followed by nursing homes, and then actual homes, right? Home health nurse. What were the most common methods? Injection. And if you think about it, it relates to the profession, right? What are the nurses mostly doing? They are administering the treatments. So injection was by far the most common. Unknown, 25%. So the other problem, like we mentioned, people in a hospital are acutely ill. So it is not difficult to end up having someone pass and not realize it's suspicious circumstances, or to even be able to get access to an autopsy, because it's not necessarily an unattended death that compels an autopsy. There's only certain circumstances that do that. And it's not often obvious that someone was murdered. They have just passed. Suffocation, so the pillow. And so if you think about that, my cursor, there we go. If you are, which type of worker, right, would be doing this? The one that doesn't have access to medications. So if you're a nurse's aide, you don't have access to the medication, then maybe you're going to be doing something this. Water in the lungs is a pretty gruesome one. So one of the common methods is they plug the victim's nose and pour water down their throat and hold them down and let them drown in water in the mouth. I should have done a disclaimer. The title is a disclaimer enough, isn't it? That this is a little bit of a disturbing topic, and purposely I'm not going to talk in detail about the infant and baby killings, but it's a pretty common thing as well, unfortunately. Oral medications that are not prescribed or in overdose, like opiates, and air embolus is also something. Poisoning, right? If you can't get access to something, you can bring something in or use the chemicals from the actual hospital to inject or ingest. And then equipment tampering, right? Kinking a hose, stopping a breathing tube, things like that. Types of injections, opiates and opioids, 23%, potassium chloride, I heard someone mention that, 17%, insulin, 13%, neuromuscular blocking drugs, pancuronium, Sux, Dig, epinephrine, lidocaine. So, you know, kind of goes down from there, but opiates and opioids, even though they're more commonly accessible to certain folks, insulin is often for nurses and was the most common type for them. Here's another case, Elizabeth Wettlaufer. This is a case out of Canada. And phenotypically, I'm just gonna say too, there is something, when you look at Reta Mays, you look at her, there's something phenotypically, I think, going on there as well. Not sure what, but something. So she was arrested in 2016 in Toronto, Canada, after walking into a psychiatrist's office, so this could be us, admitting that she'd killed at least 8 people with lethal doses of insulin between 2007 and 2016. So she was doing this for almost a decade. She got charged with 8 counts of first-degree murder, 4 counts of attempted murder, and 2 counts of aggravated assault, pled guilty, and went to prison for life. Background here is also interesting, right? So she grew up in a farming community in Southern Ontario, Canada, not Oregon. Her parents were Christian fundamentalists, and she was teased and caught asking a girl by her parents, asking a girl out in high school. So when she attended Bible college, her father attended with her to prevent her from any untoward behaviors, and then they made her attend conversion therapy. So one of the common themes in the background of many of these individuals is some sort of event that's created kind of a percolating anger or resentment towards certain figures, and that is thought to be kind of played out in the relationship they have with their victims. She ended up marrying a religious man who divorced her once he discovered she was in an affair with a woman. That broke up, and almost immediately she then took a job as a night nurse at a home for senior citizens. And within a few weeks of being there, she killed or attempted to kill her first victim. So she did not instantly become good at this. There's evidence that she had to research it. She attempted and tried and played around with the doses and what the effects were, used good old Google to search and find out how to do this. And her first death was 3 months into her job as a night nurse, 84-year-old victim. So again, you see that theme of the method of the maybe someone who's gone into it. For her, this was a different field after some sort of large psychosocial stressor. And the victim, again, is someone with vulnerability, and you have access because she's at night. She described, so the other interesting thing is, how is this happening? What is happening? What is the mental thing that might be going wrong here? She described this red surge or power or bloodlust just prior to injecting these individuals with insulin. There's a theme with veterans, and I've thought about that, and my opinion is that veterans have a lot of benefits that allow them to be in facilities, right? As opposed to typical folks in their 80s plus. So I think, unfortunately, there are a disproportionate number of victims due to their benefits and the ability to have all sorts of care that end up being veterans. So she was particularly angry. There's evidence Reta Mays had abuse in her past and her background. Same thing here with Elizabeth and her relationship with her father. So you see these male elderly victims. There's some hypothesis there that it's this kind of recapitulation of this parenting relationship. But she was angry at him. He was demented. And her next victim, she claimed sexually harassed her. And this is actually similar to Reta Mays' case, where she accused these different ill elderly patients of either physically or sexually harassing her. But it's not just women. Anyone heard of Charles Cullen? He's possibly one of the most prolific nurse serial killers, at least in America. He was arrested in 2003 and told the authorities that he'd murdered as many as 45 patients during his 16 years, working in 10 different hospitals. Now, he's one of the individuals who brings up another risk factor, which is moving jobs frequently, right? So it's very difficult to be detected if you move around. He also spiked IV, used medications, but he spiked IV bags, and he would use medications that were not ordered by the physicians. Disturbingly, he was also a veteran and was discharged, which again would be something maybe that should have come out from the military. And it was found out that he had mental health issues and had tried to suicide. And I think there's a notation even of doing one of his shifts. He was not in healthcare when he was in the military, like dressed as a healthcare provider in a gown with gloves. One of his shifts on the submarine. He committed his first murder in 1988 as a healthcare professional. And some of his background also, there's this theme of trauma and abuse. He lost apparently his mother and sister in a car accident with the sister was driving. He then, in his marriage, was found to be abusive. His wife divorced him. He abused alcohol. He was even violent against pets, all in a way that's not typical of kind of a conduct disorder type of thing, where these things were found out at least later in life and not earlier in life, which is also not something we're used to seeing. He wanted to leave nursing, but he had to stay because of the divorce and child support payments. So unfortunately, that compelled him to have to stay, and obviously developed, again, a lot of anger and resentment that likely helped fuel his acts. There's a book about him called The Good Nurse, and it talks about kind of, again, mysterious blood sugar levels crashing, etc. This is a picture of him. There's a lot of pictures of him on the internet, and he ranges from looking like this healthy, handsome guy to just completely deranged. So again, he got finally arrested in 2003, but this was despite multiple investigations at multiple hospitals stating that there were suspicious circumstances around deaths that he had presided over the patient at the end. And he ultimately was sentenced to life in prison. Interesting fact as well, during his sentencing hearing, he apparently just kept repeatedly saying, "Your Honor, you need to step down," 30 minutes straight, to the point where the judge had the security officers, gag him so that they could complete the sentencing. The way he got caught, I think, is something, again, we need to focus on detection for prevention. So how this happened, he was in New Jersey at the Somerset Medical Center. 4 people died from non-prescribed doses of insulin. So here comes our good friend insulin again, and the heart drug digoxin. So this is a multiple, I guess if you had psychopathy, which is one of the things you think of with serial killers, and it hasn't really been put out as a hypothesis per se with healthcare serial workers, but in traditional psychopathy, we'll talk about that in a little bit too, there's a variety and a range of methods. I think the fact that he had a range of methods indicates that the severity of his actions and the potential number of victims being much higher. Anyway, again, there were probes. They didn't feel like they had enough. They even went to the police. And finally, he got caught because someone wore a wire, and he confessed. The estimates, though, here's a disturbing thing to think about. They get caught for a certain number, right? But once people have died and if they've moved around, we really don't have any idea. So every one of these cases has the number that we know about, or they've confessed to. Later, they confess to more, or by going back through retrospectively, they've kind of surmised. And in his case, he's suspected of at least 400 deaths. Donald Harvey, quickly, is another male who, let me just check our time, worked as an orderly in multiple jobs in Cincinnati and Kentucky, killed more than 2,000 patients. He was on his third job when he got arrested, and included a VA hospital. You can just tell he did it because look at the eyes. Come on, people, the eyes, what? The way he got found out was that one type of person who does have a compelled autopsy, even in a hospital, would be a motorcycle crash victim in that particular state. And it turned out, and because his injuries were not fatal or life-threatening, they're very curious about what happened. And it turned out he'd put cyanide and water into a feeding tube. So it was kind of a luck thing, but he confessed and pleaded guilty to killing 37 people in 3 hospitals. He used cyanide, arsenic, insulin. And again, now that you know something about healthcare serial killers, that cluster, cyanide, arsenic, and insulin, but the cyanide, arsenic tells you that they don't have access, right? They're probably a nurse's aide. They don't have access to the medications like some of the other, like the registered nurse does. And he confessed to even more. So he interestingly died in 2017 after being beaten to death by another inmate in a prison in Ohio. Things they learned later that are important. He had been fired from the VA for storing organ samples in his locker, but they never checked, the hospital that hired him had never checked his work history. After they uncovered the murders, an administrator admitted to changing his application to make it appear that they had checked with past employers. What do we know in healthcare? We don't change your progress notes. You shouldn't do that either. So that's kind of a nightmare. And you can also imagine if you've hired this person and they do these horrible acts, obviously there's going to be quite a lot of fear of being sued, but that is not the way to cope with that. Research on Cullen showed a similar pattern where he had done things and they didn't do proper in terms of fibbing or fabricating on his applications, and he was never fully vetted at other sites. So one of the common monikers for these individuals is angels of death, which sounds sweet and terrible, right? So are they really angels of death? Elizabeth Yardley is a criminology professor at Birmingham City University in England. She studies nurses who kill. In a 2014 research paper, she identified 16 convicted of murder over the past 4 decades in the United States, Belgium, Finland, France, Germany, Italy, and UK. And that study was in search of the angels of death. So it's a specific subtype. These are a few of them. So we talked about Cullen, Kimberly Sands, Vicki Dawn Jackson, Orville Lynn Majors. There's literally just a ton to pick from, but these are a few of the ones that she is referring to. Here's kind of the demographics. Here again, you see the gender. It's a mix. The year that they committed the murders, were convicted, country they came from, the number of murders they were convicted for, and where. And I think this is interesting too, because it tells you not just where, but what ward, right? So not known, dialysis unit. Kimberly Sands was a particularly disturbing one. She was also a nurse's aide, and she worked at a dialysis unit where she injected bleach into the tubing while individuals were doing dialysis, and 2 of the patients saw this happen and they thought, well, you know, dialysis patients, maybe they were delirious, I don't know what they're talking about. So even despite being seen doing that, she was able to continue and was convicted of 5, could have been more. She brought the bleach in from home in a bag on the unit. So things like, don't let people have their own private bag when they're staying overnight with folks on the unit or observing folks who are especially vulnerable. Cardiology unit, anesthesiology and resuscitation unit, that's a very vulnerable person, right? They're completely asleep. Emergency room, intensive care, coronary care. So you can see there's a lot of them, not all nursing home, but they include children's ward, geriatric ward. Insulin, again, was the drug most frequently used to poison patients. But healthcare killers also use sedatives, muscle relaxants, blood thinners, heart drugs, and like Kimberly, bleach. Some started with one drug, moved to another as the pace of their killings increased. So again, there's some thought that the severity of the, or I guess of the killer, increases with the pace, the number, and the variety of methods. In most cases, they poisoned with things they took from the hospital. Others stole it. And you can imagine with home health, they have access because it's just right there. It's a very, so, you know, some quotes about it. It's obviously very challenging to investigate homicide in a healthcare setting. The suspects you're looking at are members of a staff that are trusted and have legitimate access to victims. They have the opportunity to harm them. It's an investigative nightmare for a lot of reasons. So what do we know about insulin killing? Since this has come up so frequently, there's a specialist, Vincent Marks. He's a pathologist and retired University of Surrey. There's a lot of these in England, professor. He's one of the world's foremost experts. He became interested in low blood sugar, or as you guys all know, hypoglycemia, in the late 50s and discovered a patient with unexpected low blood sugar from a tumor that was secreting insulin. He went on to write a book called The Insulin Murders, True Life Cases. He said the first known case of insulin murder occurred in 1957 and involved an English nurse, Kenneth Barlow, who was convicted of poisoning his wife. But cases of healthcare workers poisoning patients with insulin are rare, right? Most nurses convicted carried out their killings in the 90s and 2000s, and there were red flag behaviors, but the people don't die in a fashion that without the technology, they could confirm that this was the case unless they admitted it later. They had, again, higher death rates on their shift, struggle with mental instability, etc. So he found this himself. One of the issues with insulin killing, again, it's very difficult from the time they were poisoned to the time that it's discovered to get autopsies and proof. So you have to kind of go back in time. So it's had to wait for the technology to catch up. So in theory, to find serum insulin levels that are altered, you have to draw the blood, obviously, when they're alive or within hours of death, which is not usually possible in a death investigation of multiple victims over potentially weeks, months, or years. So both it's the presence of insulin and the absence of a C-peptide, which measures insulin made by the body, that you look for in terms of determining if it was administered insulin. There's immunoassay tests that might not be sensitive enough, but there's newer technology with mass spectrometry that is required, but it can't be used, again, because of sometimes the status of the body. Sometimes they're cremated, but it's some of these newer technologies that have allowed them to exhume bodies and look at other places. One of the, if you're not familiar with forensics, one of the common places they get really good fluid is from the eyeball, vitreous humor. The blood is susceptible to all sorts of things with degradation. So eyeball humor, which makes it sound more fun, is where a lot of the samples are supposed to be taken if it's going to be accurate. So what is a psychiatric defense to this? Why are people doing this? Is there an explanation, right? We want to think there's some sort of thing going on. One that's been proposed is this professional fictitious disorder, or a professional Munchausen's by proxy. I'm sure you guys all know what Munchausen's is. It's the making ill in terms of by proxy, your proxy. So often it's a mother, a caregiver with a child, creating illness in that child for some sort of subconscious gain, secondary gain. Beverly Allett is a first case where this came up. She was a nurse who was diagnosed by one of the experts in her case as having Munchausen syndrome by proxy. And in this case, it was a desire to kill or injure to get attention for herself. She was given 13 life sentences in Nottingham Crown Court. This was an English case in '93 after murdering 4 children and attacking 9 others. And this followed an investigation into several incidents of tampering with ventilators and pumps delivering medications. She her background also troubled, right? So there's a theme here. She had left school with barely any qualifications. She was, in her medical records, shown to have psychological issues, had been prone to self-harm. Personality disorders have been shown to be commonly diagnosed in these individuals when they're younger, often absent from her courses. She was the only student in her class unable to get a job, right, when she graduated from nursing school. But after being turned down by many positions, she got hired, unfortunately, to a unit dealing with infants and children. She started in 1990 due to a severe staff shortage, and she committed the murders either, again, by insulin or potassium overdose or injecting an air bubble in the bloodstream. There is a 2006 BBC movie about it called The Angel of Death, the Beverly Allitt story. I was going to show you a clip, but we're going to run out of time. But if you're interested in this topic, there's a lot, including Netflix, and I think 2 seasons are on Amazon, but there's 3 seasons with 10 to 12 of them featured each of nurses who kill. So knock yourselves out. And again, the question still comes up, why? Why are they psychopaths? Are they sociopaths? Are they really doing this to help people? You know, why are these people doing this? Just a quick little review of that in terms of what is a psychopath or a sociopath. So psychopath is a social predator, right? Manipulative, they lack the ability to feel empathy, they're not violent, most don't commit murder, but they're lower prevalence, about 1% of the general population, and it's not really thought, you know, psychopaths don't do this and seek out jobs in healthcare to become, you know, serial killers. It's more thought to be this unfortunate confluence of opportunity and some of those other factors that we've talked about. A sociopath is impulsive, reactive, and not the type of person that does this kind of more cool, undetected healthcare killing. Antisocial personality, not really commonly found in these. Narcissistic personality, you could say maybe some of them had that. But we do love sociopaths, right? We do love them. They're in all sorts of movies. They're glamorized. We have a lot of movies about unfortunately shows about folks who kill. And like I mentioned, Reta Mays was, her Google search included most prolific serial killers, and several of the individuals who've been convicted of healthcare serial killings cited wanting to be the most prolific one as a rationale. Just for fun, psychopath, sociopath, not really pertinent here, but again, one is more cool, calm, and collected. The other one, you know, you see more often in jail and prison, are more impulsive. So a little bit more about this Munchausen syndrome by proxy, if you're interested. Even has an acronym, MSBP. It was proposed by Repper in a paper in '95. She was the one who testified in the Beverly Allitt case. And it's similar to other types of cases, if you think about it. For instance, a firefighter who is setting the fires so that they can come in and save the day and put the fire out. Or in this case, it would be like a crime or a murder committed by a police officer, then to solve, you know, tries to pin it on someone else. So there's some thought that there's a reward element to this, to be a hero or to solve something. So you create the problem and then you try to solve it. And it makes sense if you think about maybe some of the folks who aren't, you know, as fully trained and they want to have a role where they get to save somebody. But what doesn't make sense is creating something where you injure pathologically someone or kill them to do that. So what do we do? How are we doing on time? Okay, what do we do? You know, we can't just have all this information and not do something. So it's important to look for red flags, okay? Red flag characteristics in healthcare serial murders. Number one, personal things, right? So what have we learned? There could be substance use. Interpersonal relationship issues are usually pretty significant. As you've heard so far in these cases, we've had breakups and conversion therapy and strange relationships with parents and domestic violence and spouse in prison for child pornography that you don't divorce. History of mental instability and particularly personality disorders. Many of these folks were, one was discharged from the military for mental health reasons or had significant breaks in training. So looking for things when you're looking at the longevity of the individual as far as their schooling and their professional careers, there's some patterns there for these folks. They often crave attention related to their skills and point out when they're doing things. They have a history of criminal activities, including falsifying credentials. So, hopefully nowadays we're better at that. I think it was easier a decade or two ago, but it still happens, and it's often difficult, especially when there's an urgent opening, to determine if someone's credentials are fully what they say. Even with the National Practitioner Data Bank, there can be ways to move around from place to place before things catch up with you, or if you've left a job and didn't get formally reprimanded, that may not be on a board report. Work history. So one concerning thing would be someone who moves from place to place to place, like Cullen, right? So if you go from place to place, you can't be detected. If they have a history of disciplinary problems at their prior positions, preference for work shifts with fewer coworkers, the night shift, and a history of incidents at other facilities, certainly. What you might notice of those people as a staff, as a coworker, is that they are anxious or suspicious, especially during breaks. Like, hey, what's going on? How's that person doing? They might be dubbed an angel of death, right? Like, oh, you're an assassin. Sort of like we talk about a white cloud, in residency. If you don't, get admissions, or you don't have a busy shift, some people might get a nickname. So pay attention to what people are calling someone. They like to make predictions about who might die, which sounds morbid. And coworkers of Reta Mays talked about that she would call and Facebook message someone on shift to find out if so-and-so died or if they're still alive. Found in places they shouldn't be at work. They're in the med closet or someplace else. Higher incidence of death on their shift, obviously, is something to pay attention to. They're not usually the only one on a shift, so that gets narrowed down, obviously. And they can make inconsistent statements when challenged, like, oh, I wasn't there, or, oh, I saw someone else do that. So if their story changes and it's not consistent, that is important to know as well. There is some formal guidelines from an Ontario long-term care homes public inquiry, again, Canada being another place where they've done a lot of work in this area. And the big message is safeguard the vulnerable. Like the typical thing you think, right, unfortunately with these cases, is infants and geriatric folks in facilities. But some of the issues that came up were poor hiring and firing practices, not sharing disciplinary issues from jobs where they were fired, not vetting them properly when you're hiring, institutional problems with either supervision, training, access to medications, or placing people on a shift, overnight with not enough staff, and detection. We don't routinely think of having to detect our coworkers harming people, right? And I think that the system doesn't necessarily want to go look for something they don't want to find. So detection is difficult for all the reasons that we talked about, the multiple reasons someone is in the hospital, the multiple people who have had hands-on, hopefully not all inappropriately, but on a patient in the course of their time in a hospital or long-term care unit. So it can be challenging, but there's suggestions like spot inspections by supervisors and doing things that kind of intermittently create an environment that doesn't stay the same and allow perpetrators to have the same access all the time. All right, I tried, yes, we have some time, tried to do this so we would have time to talk.
And Dr. LaCroix, there was one question that came up while you were talking. From one of the people said, the thought trails to training and counseling for moral injury, could any of those be prevented, or is the pathology of the individual a bigger piece?
Okay, hold on, I'm gonna have to read that one. Okay, so I see that one. The thought trails to training and counseling. Who is, okay, so moral injury as in the
Dr.
individual.
LaCroix, you answered it in the course of the training.
Oh, great. Yeah, so that they have, I think, are you meaning that they have some sort of kind of deep-seated?
It's all a piece of the employee, and then add pathology, and then add poor training and a desire to show the world what a wonderful, all of those things. It's all it's many puzzle pieces put together to equate to one bad serial killer.
Yes. Is that Deb? Hi, Deb.
It is. Hi.
Yeah, it is an unfortunate confluence, right? And you would think, well, this would be some rare perfect storm, but unfortunately it's not. And we are partially creating this perfect storm. So, right, it's a perfect storm of some of these demographics mixed with that availability and vulnerability. And unfortunately, we keep having that storm. Other thoughts, questions?
I have a comment. Yeah, I wonder if this is purely speculative, and I wonder if in the U.S. the incidence of these serial killers is higher, kind of maybe because our health systems aren't as interconnected as other countries. I listened to a podcast about Charles Cullen a year or so ago, and it was pretty remarkable. They really emphasize in that the podcast about him how he really just kind of went from one institution to another. And of course, like you mentioned, it was a few decades ago, but
yeah,
there was minimal investigation into his background.
Yeah, and you're right, and I think that you know, you'd hope that doesn't happen, but I mean, this lady just got convicted last week, right? I mean, or sentenced last week. So unfortunately, it is not, you know, not all hospitals and facilities, especially long-term care, right, or home health, like they don't all have the same regulations. But for Cullen in particular, just a disturbing pattern, and I think you're exactly right. It's fascinating because we don't have enough information about these people. So then everyone hypothesizes. Some have been interviewed, some have talked about their motive. But the interesting thing with all these cases is that you don't really get to know, which makes them even more fascinating, right? Because they're extremely disturbing, and you don't really get to find out. There's no aha why moment. And so you have to quickly shift into how to prevent it from happening.
Yeah, there's this, just going back to that podcast, there's this really interesting recording that they played where essentially a pharmacist kind of had identified that Cullen had killed someone with digoxin, and they recorded the pharmacist's like interaction with kind of some of the higher ups at the hospital, where the pharmacist is saying, I clearly know someone gave digoxin and killed this individual, and I suspect it was Cullen because of his, you know, shift timing. And the administrators are just kind of replying, oh, we don't really know for sure, like how hard is this? Should we really report this to the police? And I think it was actually when he ultimately wound up getting kind of caught. So
yeah, it was the person who wore the wire. And again, if you think about it, in healthcare, you know, people aren't going to be like, j'accuse, you are a serial killer, you know, so it's not something we walk around, you know, trying to accuse her. So that it's perfectly designed, unfortunately, for this type of incident to occur if someone's got those predilections. He was a particularly disturbed individual, so I think his were particularly awful. And I think he had a hubris that not all of them have. There's sort of this sad, broken female kind of phenotype. Then there's this, someone like him, I think would be on the psychopathic spectrum, due to all those factors, the types of things he did. He bragged about when he did get originally interviewed and they thought it was him, that he couldn't be caught. He was basically untouchable. No one could prove it. So it takes, unfortunately, a lot. It takes time and a lot of cases often before it's discovered. It's assumed to be an accident maybe, or a mistake. And whose mistake was it? Was it the pharmacy? Was it the, you know, whatever. And so it's just, we're not I don't think we're able, I don't know how we would be able to do that because it would be pretty uncomfortable to work in healthcare and have everyone suspect everybody of doing something purposely to injure folks. But it's a good topic to, I think, be aware of just in terms of knowing some of the signs, right? We look for all sorts of other things and get annual trainings on washing our hands and not, violating people's privacy, but we don't look for suspicious acts that are problematic. Any other thoughts?
Hi, this is Maritza. And going down a little rabbit hole, a few years back, I read this really long article about Hurricane Katrina and some of kind of the mercy deaths that happened around some of the hospitals in the area.
Yeah.
And I think one of it was like a doctor and a few different nurses that kind of went around and between them decided who would live and kind of who wouldn't, which that was like the perfect storm for just healthcare to collapse, I guess, but I think at the end, the doctor didn't end up getting convicted, but as a patient, if she was ever my doctor, I'd be like, oh, I don't know if I would trust you or how ethical you are. But anyways, it was just something that I think about sometimes, and this topic brought that whole article back up.
Yeah, I think there's different things that don't rise to that level, but that are part of healthcare too, like in a mass incident of some sort, right? Where you do have to triage. And for those of us who've been in the military, there's a process where you have to decide, that's where that term kind of comes from. Is this person about to die? Can we help them? Can we not? And you categorize people, not with the purpose to kill them, but you only have certain resources that you can spend and you need to do that. Now, deciding because you need open beds, I didn't talk about that, but one of the motivations that was found in several of the prolific killers, healthcare serial killers, was there was a kickback. So one of a really famous case back at the turn of the century was a nurse. I think she was, I don't remember if it was Jolly Jane. Anyway, there's a few from a long time ago, but they started this adoption kind of service because people were very poor and needed money, and you could get paid and they would take your baby, but they would never place the baby. They would get rid of the baby and take the money. There was also kickbacks in one serial killer case where they would get financial kickbacks from the funeral homes. So if they worked with this particular funeral home, they would get a $60 or $100 referral fee. So the more customers, the more money, right? So financial, we didn't talk about that, but financial distress obviously is linked to the desperation, and it is also linked to other types of crimes, right? Embezzlement, people who embezzle from companies due to all these same factors, and then severe financial distress. So more disturbing reasons.
And I think we're at 1 o'clock right now, not to end on such a high note, but thank you so much, Dr. LaCroix, for coming to talk to us. If anybody else has any other questions, I'm sure she's happy to answer them or reach out if needed, but we'll go ahead and probably end for now for lunch and everything. Does that sound okay?
Yes, bye.
All right,
Thanks,
so
Camille.
much.
It was wonderful.
Yeah.
Excellent. Bye.
Have a happy day. Don't, think about this topic anymore. Hi, Christy. Hi, Larry and Liz. All right, I'm gonna let folks go do their job. Hi.